So is that everybody, Joanna?
Yeah, I'll let people in as they trickle in, but that's everybody for now.
Yeah. Do you want me to start then, Beck, or do you want to
Yes,
say?
please. Yeah, I think we make a start. Thanks.
Okay, so hi everybody. Welcome to today's seminar, which is going to be run by the digital health theme in ARC. I'm going to start off by doing a very brief overview of the theme and what we're up to at the moment, and then Theodora and Mike are going to talk in a bit more detail about one of the projects that we've got ongoing at the moment with MFT, looking at do not attends and predictive modelling. If you've got any questions, and you're going to forget them by the end, just pop them in the chat. But we're going to do all of the questions at the end of presentations rather than interrupting, if that's okay with everybody. So without further ado, I will just start and share my screen. There we go. Can everybody see that? Yeah. So yes, welcome to the ARC Digital Health theme. For those of you who don't know who I am, I'm Dowding, I'm the theme lead, and I would also like to say hi to Sabine, who I think is on the call as well, who's our theme deputy. I thought it would be a good idea just to give you an overview of who's involved in our theme, just in case you've not come across some of us before. So alongside myself and Sabine, there's Niels Peake, John Ainsworth and Will Dixon, who are academics at the University of Manchester, and Charlotte Sharp has just joined us, who's a consultant rheumatologist at MFT. We also have quite a few research associates. Theodora and Mike will be talking to us today. Have Mustafa, who's doing most of the work on our health and equities work at the moment, and Louise Laverty, who's on maternity leave but very soon to rejoin us. Richard Williams, who's the software engineer who works with the Greater Manchester Care Record, and then also big thanks to Ross and Karen, who support our theme through the ARC administration team. In terms of the sort of work that we said we would do when we put in the proposal, we do the design, implementation and evaluation of new digital technologies in the NHS with our NHS partners. And the role of those technologies can be everything from disease prevention, self-management and personalised care. And we focus on looking at attitudes and understanding of professional and public to different technologies. And we've done some work with citizen juries, particularly during the pandemic, looking at that. Working with our NHS partners to facilitate implementation of digital health, and really looking at different ways of evaluating and developing technologies to support patients, clinicians, and the wider public in using digital technology to support health and well-being. I'm not going to go into all of the aims in a great detail. We had a few projects that we were involved with when ARC first started. So Patches was is a predictive modelling triage system for use in primary care. We were doing some work looking at how we could triage heart failure patients using smart technology. SMASH, which Pete Bauer can probably talk much more about than I can, to look at GP prescribing in primary care and the safety of that. And as I said, we also have carried out some citizens juries looking at issues to do with data sharing during the COVID pandemic. So all of that work has now been completed. It was completed towards the tail end of last year. And we're now focusing on quite a number of different active projects that are in a variety of different stages of development. So we have a piece of work which Theodora and Mike are going to talk to you about today, looking at no-shows or do not attends in outpatient clinics in the local trust. This is obviously that sort of issue of effectiveness and use of resources in the NHS, and do not attends and people not turning up is obviously quite pertinent at the moment, and we're going to talk a bit about that work. We've been working with the Greater Manchester Care Record and Richard looking at there's some projects looking at healthcare utilisation during the pandemic, and going forward we'll be using the GMCR, I think, for a variety of different projects. Mustafa's been heavily involved in a programme of work alongside Sabine looking at digital health and equity, and we're doing that in collaboration with the Pankhurst and a variety and University of Toronto and Melbourne. We've got some work looking at trying to develop software for health apps so that we have like a generic platform that researchers can use that can be adapted for different projects to try and stop us try and prevent having to develop software from scratch every time we want to develop a new health app. And that was some work that Matt Machin was involved with, and unfortunately he left the university at the end of last year, so John Ainsworth and I are going to be taking that forward. We're still in discussion with the Northern Care Alliance about trying to evaluate their connected care project, which is a bed flow management system, and hopefully we'll have some more insights into that recently. Exploring community experiences of health data sharing with the Patient Safety Translational Research Centre in Caroline. Norina's PhD project looking at augmented reality for hand hygiene, and then a variety of other projects in planning that we're working in collaboration with MFT. So that was really me just giving you a very brief overview of some of the things that we're involved in at the moment. I didn't want to take up too much time today. But if anyone's interested in some of that work, then please just shoot me an email afterwards. And I'm going to hand over to Theodora, who's going to talk in a little bit more detail about our DNA prediction work.
Thank you, Dawn. So hopefully you can all see my slides full screen right now. Yes, thank you. So I'm aware that some of you have heard me talk about part of this work already, so I will just briefly mention some parts of this work, and I will go into more detail about others that I haven't presented to you yet. The topic of this project is did not attend, specifically outpatient did not attend. So these are appointments that patients miss without giving prior notification to their healthcare provider. You've probably heard about this topic because it tends to pop up in the media and be talked about by politicians every now and then. And the main reason why there is sort of a popular interest in missed appointments is that they carry a cost for the healthcare system. So there's one estimate that has put the cost of missed appointments for the NHS at £750 million annually. From a research perspective, it is a complex topic to develop interventions for, and that is because there are many determinants as to why people miss their appointments. It could be something very simple like people forgetting that they had an appointment. It could be people who get an appointment weeks or months after, or 4 weeks or months after the time they try to book, so their complaint possibly gets resolved or they see another practitioner. And it could be more complex things and possibly related to equity, such as people being unable to afford public transport, travel to the hospital. So many different interventions have been developed to tackle these many different determinants of missed appointments. We do know that sending text message reminders to patients who have an appointment generally work and they increase attendance. And there are many other interventions for which there is less strong or less consistent evidence. And this include providing transport to appointments, financial incentives to come into appointments, and also double booking appointments to avoid costs in the clinic. Now, our project, it came about as essentially a request by the Manchester Foundation Trust to come in and evaluate such an intervention to reduce missed appointments. This intervention is based on a predictive model. The model essentially is an algorithm that identifies scheduled appointments that are at very high risk of being missed. This predictive model is being implemented as part of a larger program of implementing the Hive digital record. So this is a new electronic health record that is being implemented in the MFT. So we were invited to evaluate this new predictive model in around March 22, in early 22. The first step in in our work was to conduct a rapid review to figure out how such predictive models have been used and what interventions have been developed around them to reduce missed appointments. After the rapid review had been completed, we had about 2 months until early September, when the Hive electronic record would go live. So in this 2-month period, what we did was some preliminary qualitative work based in interviews with staff, clinical and management staff at MFT, to figure out how they are currently dealing with missed appointments and also with appointment scheduling in general, and what their perceptions of the predictive model were at the time, in order to essentially have a baseline to later evaluate the predictive model after its implementation. This brings us to early 2023. At this point, Hive as an electronic health record system has gone live and is being used. However, the predictive model is still being calibrated. So in the background, data about attendance in the local MFT patient population are being collected, and the model is being locally validated. The model itself will go live in late spring 2023. At this time, there are some parts of this project that we are currently planning, which will include a qualitative evaluation with interviews and observations, as well as a quantitative evaluation of the impact of the use of this predictive model to reduce no-shows. And I have already presented the rapid review that we did and the results that we found, which is also already published. So you can refer to the full text and have more information there. I'll briefly say that we found 4 different types of interventions based on predictive modeling. And 3 of them, we found fairly robust evidence that they were effective at reducing no-shows. In these interventions, the predictive model was used to identify appointments at high risk of being missed. And the co-intervention was either sending a text message reminder or implementing a phone call reminder to these patients, or implementing patient navigator phone calls. In patient navigator phone calls, a trained staff member calls patients and supports them in lifting barriers to get them to come into their appointments. The 4th type of co-intervention we found was overbooking, where the appointments that are predicted to be at high risk of being missed, they are double booked. But unfortunately, it was not clear whether this intervention really has an effect at increasing attendance, partly because of the quality of the studies that we found. We also found that there were no studies analyzing the process of implementing these interventions and these predictive models. And there was also very limited and often anecdotal evidence on how acceptable these interventions were to patients or healthcare staff, and also limited economical evidence on the cost and the cost effectiveness of these interventions. The second part of our work, as I mentioned, was a round of interviews with MFT management and clinicians, where we try to find out what the current state of did not attends are in MFT, in their clinics, and how they intend to use a predictive model in the future, and what are their perceptions regarding its advantages, disadvantages, and facilitators and barriers in its implementation. So we carried out semi-structured interviews with 6 managers and clinicians from gynecology, diabetic retina, vascular surgery, dentistry, and orthodontics. And the interview was informed by the review that I already presented, and also by patient involvement work that we do in this project with the ARC-GM PCIe panel. The main findings from this interview study were that there's high heterogeneity among clinical units in MFT regarding both the frequency of non-attendance, its impact, as well as current strategies for its management and also intended uses of the predictive model. For the current DNA management, some MFT clinics reported that they have limited access to data about their DNAs, and also limited ability to dig deep into their current non-attendance data. So limited ability to figure out which patients are most likely to be missing appointments by doing some quantitative data analysis. And one of the key perceived benefits of having access to this predictive model was that whatever intervention they decide to implement, it would be based on data provided by the predictive model. So it would be adding information to their decision-making process in the management of non-attendance. In terms of which patient profiles they believe are more likely to not attend, they confirmed what we already know from the literature. There's many different reasons why their patients do not attend, and there's no single type of patient that doesn't attend. And in terms of the current management, the management strategies that they use to reduce missed appointments, they did mention that they have a wealth of strategies, text message reminders before appointments take place, for example, and in some cases calls to help patients come in. But they also mentioned that these strategies are often inefficient and they may lead to more non-attendance. For example, text message reminders often seem like they offer patients the ability to cancel the appointment by answering the text message, but actually these cancellations don't always get picked up on the side of the clinic, so they do look like no-shows. In terms of the impact of non-attendance, from the patient perspective, they sometimes lead to discharge. And in other cases, in some clinics, for example, in diabetic eye retina, clinicians need to take extra time to figure out how to adapt the patient's care plan if there is non-attendance than if the patient had attended. Now, in terms of the future intentions for using the predictive model once they have access to it in 2023, most suggestions by MFT staff were about using the model to identify patients at high risk of not showing up, and then implementing some targeted contact with the specific high-risk patients, either using existing means, so focusing their staff on calling the specific patients to confirm their attendance, or perhaps once they know a little bit more from this predictive model about who is likely to not show, using adapted modalities to reach out to these patients. For example, assuming that patients who do not have English as their main language are more likely to not show, they could adapt text messages to go out in other languages and not just English. Other ideas had to do more with adapting the patient's care. For example, in orthodontics, revising care plans to have, let's say, more feasible goals that would fit the predicted attendance of the patient. And also double booking appointments at high risk to be missed was not considered an ideal course of action, but alternatives were proposed, such as shortening the time allocated to appointments that are at high risk to no show, so that if they actually do not show, the damage from that is mitigated in terms of costs and lost time. All clinicians mentioned that the predictions of the model would not be followed blindly. They would be combined with the clinician's own knowledge of the patient and their case. For example, if a patient was predicted to be at high risk of not showing up, but was aware that their next appointment involved something they look forward to, such as taking off their braces, then they would override the prediction of the model and they would assume that the patient will actually show up. There were some potential risks that were identified by clinicians and managers associated potentially with the use of the predictive model. The main risk was that should a clinician or a manager or an admin staff member be repeatedly exposed to a patient being labeled as likely to not show, this may lead to the development of some subconscious bias against this patient. For example, a clinician may feel that this patient does not value their services adequately. There's also the risk of some of the predictors that go into this model, which refer to the individual, such as demographics or other clinical information, being seen as stigmatizing should the specifics of this model ever become known by patients or by the public. In terms, finally, of facilitators and barriers to implement interventions using this predictive model, the skills and the training and education of the staff and their ability to use this digital element was considered more than adequate. And at clinic level, there was a strong interest in reducing no-shows. There are some facilitators that are missing and that would be desired by the interviewees. The most important was to have some more information about what type of interventions that they can use with this predictive model are effective and have been shown to be effective based on research. And also they generally wanted to know more data about the accuracy of the predictive model, specifically at clinic level or either at sort of disease group level. The perceived barriers were primarily that having the model state which patients are likely to no-show does not explain why these patients are likely to no-show. So that doesn't help clinicians and managers select the right intervention to get this particular patient to come in. And in any case, some determinants of no-shows are non-modifiable or non-modifiable with the interventions that MFT can develop at this time. There were also some interviewees suggesting that there are other interventions that could be implemented at this time that might be more impactful. For example, fixing issues with the existing appointments scheduling process, such as the errors that happen with reminder messages that I mentioned earlier. Some staff considered that no-shows might be a priority or very important for them at clinic level, but they're not a top priority for MFT. And finally, to implement some interventions that are more resource intensive, such as calling patients at high risk of no-show, they would have to have adequate funding to support the staff time that should be allocated to that. It should be mentioned that these findings are in line with the discussions we have been having from the beginning of this project with the PCI panel of our Greater Manchester, who have also highlighted the need to have meaningful interventions with the predictive model that address the actual reason behind no-shows, and also the need to improve the current appointment scheduling methods. They have identified that there's a risk of bias against patients by the use of the model by labeling patients as likely to no-show. And they have asked that future research uses outcomes that measure the impact the predictive model has on patients. So this is what has already been done, the completed steps of this project. For the qualitative work, the future steps include 2 rounds of interviews. 1 round of interviews with clinical admin and management staff of MFT right before the predictive model goes live. And this is to understand the impact that Hive has had on appointment scheduling and management. And a 2nd round of interviews right after the predictive model goes live to see how it has affected no-show management. And a series of observation sessions with staff during their use of the predictive model on Hive when they perform appointment management and no-show management, which will again take place after the predictive model has gone live in late spring. So this is it for the evidence synthesis and qualitative work. And I will now hand over to Mike, who will talk to you about the quantitative work.
You're on mute, Mike.
Thanks. Thanks, Theodora. So I'll talk about the quantitative parts of the project. I'll be fairly brief. I have limited results to show you at the moment. But I can tell you about some preliminary analysis based on aggregate DNA data that we have already received from Manchester Foundation Trust, and we're currently working on gaining access to patient-level data and also post-hive data. And then I can tell you about our plans for future analysis, which is to look at determinants of DNAs, and also to look at the impact of hive implementation on DNAs, and then also to look at the impact of the predictive model built into Hive on the proportion of DNAs. So we currently have aggregate data from MFT on outpatient attendance status for the period January 2008 to July 2022. So this is all pre-Hive data. And we have monthly outpatient appointment data aggregated by site, so across the 15 sites across MFT. A speciality, 115 specialities in total across all sites, because we wanted to look at variation in DNAs across different sites and specialities. And then we have attendance status. So we're interested, of course, in particular in DNAs, but we will look at all of the attendance status categories, and in particular cancelled by patients. I'm keen to look at that, and also to look at the time when patients cancel their appointments, because patients who cancel their appointments within a day or two of the scheduled appointments, then operationally that's likely, I think, to have a similar impact as a DNA. So these are the kind of headline figures. So this is across the whole period 2008 to 2022 across all sites and specialities. So there were nearly 32 million appointments in total across this whole period. So a very small proportion of patients arrive late and are not seen. About 71% attended, 10% cancelled by provider, 10% cancelled by patient, 9% did not attend, and a small proportion, less than 1%, with an unknown attendance status. So this is the current state of play. We do see variation in DNAs across different sites, ranging from about 7% in a few sites up to about 12% at Rochdale Infirmary. There's also significant variation by speciality. So infectious diseases has one of the highest DNA rates, around 20%, and oral and maxillofacial surgery has one of the lowest DNA rates, about 4%. So these two things are related. So obviously different sites will have a different mix of specialities, which will explain some of the variation between the sites. And I think also there'll be differences in the patient mix across different sites in terms of patient determinants of DNAs. So different sites might have a different mix of age and deprivation and ethnicity, for example, which might also explain some of the variation. I'm keen to try and understand better this variation by speciality, because there is quite stark variation by speciality. And initial conversations with colleagues at the Trust suggested that maybe certain specialities patients might be more likely to be admitted, and then once they're an inpatient, they miss their outpatient appointments. Colleagues at the Trust have had an initial look at this, and it doesn't seem to explain that large variation that we see between specialities. But I would like to try and unpick that a bit further once we have access to the patient level data. So then we want to go on and look at factors associated with non-attendance. So there's quite a bit of data on this already, including a systematic review of 115 studies that identified more than 40 factors associated with DNAs. So this isn't an exhaustive list, but these are the most widely studied factors as identified by the systematic review. So age, sex, ethnicity, socioeconomic deprivation, lead time, prior no-show history, and distance to clinic have all been linked with likelihood of DNA. So I think when we look at determinants, we'll be guided by the literature, and also we'll need to be pragmatic. We're using routinely collected data collected by the trust. So there may be limitations depending on what data the trust collect. Then we want to go on to look at the impact of the implementation of Hive on DNAs. So this is kind of putting the predictive model to one side for a minute, because initially the predictive model will not be used, but just the implementation of Hive itself will have an impact on the way that appointments are scheduled and managed, and that in itself might impact on DNA rates. So we're planning to do some interrupted time series analysis to look at this. And then also we want to look at whether the implementation of Hive has an equal impact on DNA rates across different patient groups. So this will be informed by the earlier analysis where we're looking at determinants of DNAs and where we identify patients that are at increased risk of DNAs, to look at whether Hive has an equal impact across those groups. So for example, across age, sex, ethnicity and deprivation groups. Just a quick example of an interrupted time series study. So this is an example from a study from Scotland that looked at the impact of emergency department reconfiguration on emergency department trolley numbers. So the vertical line in this example represents the date of ED reconfiguration. And the general idea of an interrupted time series is to fit a model to the data before and after the implementation. So in this case, a straight line before and after the implementation. And then you can look at whether there's a difference in the intercept and slope to see whether the intervention appears to have had an impact. So of course, in our case, the intervention will be implementation of Hive. So usually there's a stable trajectory before the intervention and a stable trajectory after the intervention, and then you can make a kind of reliable comparison. In our case, the DNA trajectory is less stable, as we will see. So based on the aggregate data that we've received, I've just plotted here the percentage of DNAs over time. So this is from 2008 up to 2020. And each dot represents the percentage of DNAs in a particular month. So the long-term trend is already decreasing. So from 2008 to 2020, DNAs decreased from about 11% down to about 8% overall. And then in 2020-21, we have this disruption, of course, due to COVID. So there's a dramatic decrease in proportion of DNAs, followed by an increase, which then seems to kind of tail off and is coming down in the latest few months for which we have data, but it is still above the pre-COVID levels. So we already have this interruption, so there's a relatively stable trajectory, and then there's this interruption due to COVID. And what we want to try and answer is, has Hive had an impact on this trajectory? So if we imagine that Hive was implemented after this second dashed vertical line, we want to look at what happens after this, and has Hive had an impact on this trajectory? So this will be complicated by this disruption that we already see due to COVID. I suspect as well that there may be some temporary disruption in the immediate post-hive implementation, just because you know, the rollout of a new trust-wide system is likely to have some temporary glitches, and I think we've heard anecdotally from colleagues at the trust that there are some kind of teething problems in the immediate post-hive phase, so things might get slightly worse potentially before they get better. So these disruptions will add some complication to the modelling. So in summary, we can see from the data that we have already that the proportion of DNAs varies by site and speciality, and we know from the literature that DNAs also vary by other determinants such as age, sex, ethnicity, and so on. The interrupted time series is already interrupted by COVID, and there may be some temporary disruption in the immediate post-hive phase, which will add some further complication. So we'll need a period of sufficiently stable data to be able to make those reliable comparisons pre and post-hive. So that's it for me from now. So hopefully I can come back at some point and give you some more detail about some results. So thanks.
That was great. Thanks to both of you. So I'll probably go to the questions in the chat first. Can I just ask a quick question? And just for context, because this is all MFT data, isn't it? So is that, so all the 9% for DNAs and all the numbers you've just shown, Mike, is that comparable nationally? Is MFT quite standard? It's not an outlier?
Yeah,
one
no,
way or the other?
I think it is comparable nationally from what I've seen. I think that is around the national rates. I mean, there have been international studies and there's quite a lot of variation internationally, but I think for the UK, I think around sort of 8 to 10%, I think is about right. I don't know, Theodora might well know the literature better than I do, but
yeah, so I think the estimate I've seen for UK from 2019, I want to say, was around 8% missed outpatient appointments. And as Mike said, there is a lot of variation from country to country after that.
Okay, brilliant. Thank you. I'm going to go through the questions in the text now, if that's all right. So I think, Emma, you got in first. Do you want to just come on and ask the question, or do you want me to read them out?
Yeah, no, I'm okay. I'm just getting into the chat again.
Hi there.
So, hi. Yeah, I'm just sort of reflecting on my own experience of running a clinic. So that's where some of the questions that I've had have come from. Just trying to, yes. So it's interesting. So I guess one thing is, it'd be really interesting to look at the variety of clinics offered and whether age still comes out, because I know, for example, geriatric medicine, some organisations don't necessarily offer outpatients any longer, and also whether there's a difference between like hot clinics compared to more long-term condition management, and whether there's differences there. Because I can't remember the exact DNA rate that I used to have, but we did have a relatively high DNA rate. And so we took to my secretary calling patients. And one of the things is what's hospital factors, what's patient factors. And some of it sometimes was hospital factors and hospital glitches. And the patient factors, what's been really interesting is my secretary calling those people to find out why they didn't attend. And often there has been, particularly, well, this is for older people, there's been a really good reason why they didn't attend, like they've been unwell or they've been in hospital and the letters came to their home address whilst they're in. So it's just whether, I appreciate that, really drilling down into a bit more detail, but it would be really add another level of richness to the data if you were able to do that. And my second point was, people either don't come or they do. They're rarely late. So basically, as soon as the minutes tick off after that appointment, you can tell pretty much that they're not going to come unless the bus has been late or something absolutely out of their control. And then the final point was, it's something I've been thinking about for a while, particularly again with my patient cohort, whether having multiple appointments adds to that and whether you're able to pull that out in terms of your predictive model, because it does seem sometimes, and that would have another knock-on effect, not just reducing DNAs, but reducing numbers of outpatients and use of resources, which might be appropriate for some patients. And currently, certainly our systems doesn't flag that up. If people have got like 4 different specialty appointments, they start DNAing some of them depending on what's happening at the time. So sorry, that's a lot, but really, really interesting. I was just trying to look at my dashboard and see what DNA rates were on average, but bearing in mind we've got an intervention that's already in place, but it is resource intensive. But I would say the richness that we get back from those phone calls is really helpful. And sorry, final point, if they do DNA, are they more likely to be readmitted? Because again, we sometimes found people DNA because they're just not well and they end up coming into a hospital in the meantime. So you kind of assume people DNA because they're okay and they don't need that healthcare utilization, but maybe the converse is actually true. So yeah, that was my brain dump.
Thanks, Emma. I know, Pauline, I think you shared some personal experiences as an MFT patient, so that's in the text. I didn't know, and then others have recognised this. I didn't know if you wanted to add anything else.
Not really, just to say, I think it's right to just flag that, you know, some of these DNA, you know, are they really DNAs? Are some of them really DNAs? Because, you know, I was desperate for my appointment. I'd been waiting for over a year and then had a series of appointments where I was actually informed when I actually rang to say, has my appointment come? And then said, oh no, you didn't come. So, you know, I never got the appointment. So, and the My MFT just isn't working really. Great when you get in, but it's sort of, they said to me, oh, it'll be solved by this, you know, sign up to it. I can't get into it.
Oh, thank you.
So
I can see there's some others. So sorry.
It was just that personal view really of hospital versus patient practice and how to kind of put those in really, I suppose.
Yeah, thanks, Paul, and I appreciate some others. So Charlotte as well, and others have recognised these, you know, anecdotally, but from a personal perspective. But then it links to the issue that's been discussed about, you know, whether there's good data on this from the patient perspective. So yeah. Thank you for all that. Jill, do you want to ask you a question about the mechanism?
Sure. Hi. I was just thinking that for, you know, some groups of patients, they really aren't in control necessarily of whether they attend or not. It's down to whether a carer or someone is available to come to get them to the hospital and support them while they're there. So maybe we need to be considering that as a particular factor. You're not necessarily contacting a patient, you may be contacting a carer to make sure that they're able to bring the person, for example, with particular groups. You know, certainly that would be all children under a certain age. It would be a lot of older people, a lot of people perhaps living with disability, and so on.
Yeah, thank you. I can see, Anila, you've put in an experience about your mum as well. I'm going to, Pete, your hand's been up for a while. Do you want to add your question and then we'll go back to the chat?
Yeah, really interesting stuff. So thanks for the presentation. I suppose it was kind of bringing those two issues together. This isn't my area at all, so apologies if it's a naive question, but Mike showed data, it's kind of trending down. And I suppose at some level there must be a rate at which you just can't squeeze any more out of the system. You know, the bus is late, I'm dependent on X to drop me off, and I just wondered, it just felt like I wondered what is that level at which you're never going to get 100%, and it felt like, well, 10% is not a million and it's trending down anyway. So it's just that broader issue about how much scope do you think there is to actually improve on because it feels like it's close to that level anyway. But again, not my area, so that apologies for that naive question.
I'll take that, and then if Theodora might want to add their tuppence worth. I sort of think that's a really interesting point, and I don't think there's any consensus about what that rate should be. And I wondered, but I think one of the issues is actually more interesting, I I think, is this variation between different specialties and different sites. So it may not necessarily, it maybe not necessarily be, you know, maybe 4% is where we should be aiming, which is the lowest rates we're seeing in some other places. But we're probably saying that 20% for infectious diseases is probably too high.
Yep.
So what is it about that particular specialty and the characteristics there, which mean they have, and there's all sorts of underlying issues around all of that, which I sort of feel like this study is just scratching the surface of. But you know, so I think we'll be able to drill down a bit. I think we'll take away some of the comments about patient experiences and organisational issues, because I think that's really important. We may well, it's helpful that we haven't put in the proposal yet for the second phase of data collection, because we might add some stuff in there. I can see Theodora going, oh no. But I do think, but I think that that's actually one of the biggest issues, is how far down. It is never going to be zero, but what should it be?
And I think that just to respond to that, I think the issue that you've identified there about, you know, if it's certain clinics, I suppose then it's about, well, how good a generic intervention is going to be compared to something about infectious diseases. But yeah, just absolutely fascinating. So thanks.
And I think it's worthwhile saying that this predictive model is actually something that's inbuilt into the EPIC system that MFT bought. So it's been developed for a very different population. So so it will be amended to the MFT population, but of course that then, you know, that there are other places in the UK that also have it, and we might end up being able to do some quite nice comparison work across other hospitals as well. Sorry, Mike and Theodora, do you want to?
Yeah, so my I guess comment, my answer to that is that, as I suppose with all complex or behavioral interventions, the question is how much of what proportion of the missed appointments are due to modifiable factors, and what proportion is due to non-modifiable factors, which we have to accept that will remain, therefore will never go down to zero. And we know from a couple different sources that there is a bit of room in modifiable factors that can reduce no-shows. We know this namely for MFT from the inefficiencies we've already noticed in the system that notifies patients they have an appointment. Doesn't work, therefore they miss appointments. This can be fixed. And we already know this from essentially what Emma mentioned, which was also done in some clinics where we interviewed staff, where you have phone calls, nurses or secretaries calling patients who missed an appointment to figure out why they missed it and to help them not miss the next one. So again, in this process, they do discover some modifiable factors. So there is room for improvement. But yes, so I absolutely agree. We'll never get down to zero because sometimes there's a train strike. So.
Thanks.
Thank you. Thanks. Louise, did you want to ask your question about the breakdown by type of appointment?
Yeah. Hi, sorry. Yeah, sorry, I'm sorry. I missed it. Did you do break it down by that? By type of appointment?
So do you mean whether it was face-to-face or telephone or?
No, if it's like, say, so for instance, if you're really worried about something, you might have an appointment for your initial appointment for assessment, but then like get scared and not attend. If you finally got your appointment and you've had a diagnosis and then you're booked in for treatment, you're probably more likely to attend. If you've then been treated and you're all right, you might not be bothered going up for the follow-ups. So I just think it's quite a difference in that type of appointment.
Yeah, to add to that, new versus follow-up. So patients might be more likely to attend when it's their first attendance, whereas a follow-up, they might think, oh, there's no point, what are they doing? Nothing ever changes, yada, yada, yada.
Also, just another comment, I was interested about the how it differs by type of specialty, because I mean obviously they're so different, but it was just the I mean the infectious diseases, you said it had the highest rates of DNAs, but then that's so broad in itself, isn't it? I mean obviously what does that mean? It's very difficult to actually pin down what that actually means, you know. But also just to comment about the oral maxillofacial thing. I used to, years and years ago, I used to work at a dental hospital, and those appointments to have surgery or whatever for those, they were so prized. It was unbelievable. And so that sort of thing about how difficult it is to get the appointment, also the quality of life that's affected while you're not getting that appointment, because there used to be patients that had like 2 years eating nothing but porridge, you know. So just that comment. Well,
yeah, thanks. They're really useful comments, and I think that's right. Kind of trying to understand the value that patients place on their appointment, because I think there are some cases, as Theodora mentioned, if somebody's got an appointment to have their braces removed, then someone will probably place a really high value on that appointment, and so they will attend. As you said, if somebody's got kind of a routine follow-up and actually they've been fine and they've got no problems and nothing's changed, they probably place a low value on that, and so they might well not attend. Yeah, I think it's probably quite tricky to unpick that or to measure that, but yeah, I think you're absolutely right.
I had that. What was the data that you were getting this off? Because I had some patient admin system that I was using with the Manchester Arena Resilience Hub, and I had that as to what type of appointment it was, but it obviously may be different. That's Pennine Care that was at the time. So.
Yeah, this has come from the trust, from the electronic health record at MFT. So we may well be able to get some more detail about the type of appointment. So I will ask about that at the next meeting. Thanks.
Okay. Thank you.
Okay, brilliant. I think if there's no more questions, I think we'll probably wrap up if that's okay. So thanks to Dawn and Theodora and Mike, 3 really good presentations. And thanks for, I know there's a lot of comments in the chat, and the you know, all the personal experiences are really useful as well. So as I said, I'll save all that. I'm sure that'll be really useful for the team to have as I think through all the stuff, especially the patient perspective stuff. Yeah. So yeah, thanks everyone for coming. The next one of these seminars is the 8th of March, and that's the mental health theme. Brilliant. So yeah, thank you very much.
Yeah, we've really appreciated the feedback. It really helps with the one of the benefits of having something like this is it can help feed into the next phases of the project, which is brilliant. Thank you all.